Welcome to Hand Surgery Resources Podcast. Welcome to Hand Surgery Resources Podcast on Pediatric Trigger Thumb, or as it is sometimes called, Congenital Trigger Thumb. As a parent, grandparent, or caregiver, you may have seen a child complaining of inability to straighten his or her thumb. They may also complain of a lump on the palm side of the thumb or heard complaints that the thumb clicks and hurts. These complaints could be secondary to a pediatric trigger thumb. Pediatric trigger thumb is characterized by a thumb IP joint flexion contracture and by a tendon nodule at the level of the metacarpal head called a Notta's node or nodule. The pathophysiology is thought to be stenosing tenosynovitis of the flexor pollicis longus tendon. Abnormal collagen degeneration and synovial proliferation cause the flexor pollicis tendon to thicken relative to the A1 pulley at the MP joint. This disrupts the normal tendon gliding and results in the catching and locking that is observed. There is an ongoing debate whether this condition is present at birth or develops in the early postnatal period. Anatomic structures related to the pediatric trigger thumb are the thumb IP joint, the thumb metacarpal head, the flexor pollicis longus tendon, and the A1 pulley of the flexor tendon sheath. Pediatric trigger thumb is a separate entity from adult acquired trigger thumb. The incidence of pediatric trigger thumb has been estimated to be 3.3 cases per 1,000 live births. Boys and girls are affected equally, and approximately 25% of the cases occur bilaterally. Pediatric trigger thumb can be associated with congenital syndromes like trisomy 13, but these associations are very rare. Usually, pediatric trigger thumb is an isolated event. The differential diagnosis includes congenital hypoplastic thumb extensors, congenital absence of the thumb extensors, thumb trauma, and very rarely arthrogryposis. The symptoms of pediatric trigger thumb include a tender lump or nodule under the first flexion crease of the thumb, called the Notta's node or nodule, limited painful thumb motion, a bent thumb tip, which is caused by a flexion contracture of the thumb IP joint, and finally there may be complaints of painful clicking, snapping, catching, or triggering or temporary locking of the thumb in a flexion or extension posture. As the thumb unlocks, sometimes it is so painful that the child may cry. The physical examination findings associated with pediatric trigger thumb include a lump or Notta's node, which can be seen or sometimes felt on the palm side of the thumb MP joint, and often this nodule is tender on examination. Additionally, the thumb IP joint is frequently locked in flexion, or there may be limited active and/or passive thumb IP and thumb MP joint motion. The passive motion exam may demonstrate painful catching of the thumb. It will appear that the catching is occurring at the thumb IP joint, which is at the base of the thumb nail. This appearance occurs because the distal part of the thumb snaps usually into extension as the locking is released. Despite this visual observation, the real catching or locking is occurring at the thumb MP joint level at the A1 pulley of the flexor tendon sheath. The abnormal motion can have a ratcheting pattern to it that will be observed by the examiner. The treatment options for pediatric trigger thumb include splinting, passive stretching exercises, or simple observation. If the pediatric trigger thumb does not spontaneously resolve by 12 months of age, or after 6 to 12 weeks of treatment and/or observation, or has been present for a prolonged interval prior to presentation to the surgeon, then surgical release of the thumb A1 pulley should be considered without a trial of conservative management. Surgery is often performed between the ages of 2 and 3 and is done under general anesthesia. Potential complications are very rare but can include digital nerve injury, wound complications such as skin contracture or infection, thumb IP joint active flexion deficit, and/or bowstringing of the flexor pollicis longus tendon. Treatment outcomes are usually excellent. Spontaneous resolution occurs in 30 to 60% of cases. Most pediatric trigger thumbs seen before 12 months of age will resolve spontaneously, but only 10% or less will resolve after the age of 12 months. Extension splinting will resolve 50 to 60% of the cases, but there is a high dropout rate. Surgical A1 pulley release can provide resolution of the problem, and success rates of 95% have been reported. In review of the key points related to pediatric trigger thumb, we should remember congenital trigger thumbs are not congenital. Pediatric trigger thumbs may lock and are not necessarily triggering at the time of presentation. Several exhaustive studies of newborn infants have found no cases of trigger thumb present at birth. Therefore, the preferred diagnosis is pediatric trigger thumb, not congenital trigger thumb. The condition usually develops between 1 and 3 years of age and presents with a flexion deformity without antecedent triggering or trauma. The results of surgical treatment are uniformly excellent, and trigger thumb release is thus considered the most effective and conservative treatment option. Extension splinting is sometimes effective, but it is tedious with poor patient compliance. Steroid injection is helpful only in adult trigger thumb. It is not an option in pediatric trigger thumb treatment. For more information, visit www.handsurgeryresource.org and look for our comprehensive online text hand surgery source or our hand surgery source app at the Apple Store or at Google Play. Thank you for listening.